Okay, so first, talk about ABG. How do they do ABGs? Radial arteries, usually. Right. I'm not sure if your med-surg textbook calls it the Allen test, but I know the ATI one does, and it's the common terminology. So you'll probably see that on NCLEX that they talk about an Allen test, A-L-L-E-N. Huh? Allen, I guess so. And so you see you have your two arteries, right? So if one is occluded, your hand is still being perfused, right? So if I stick this artery, this radial artery, then it's kind of clotted off. It's going to get a hematoma while it's healing. Then I can still be perfused with this one, right? This is why we start here. And if they need subsequent ones, or if it's getting difficult, we'll go up to the brachial artery. But how many arteries do you have here to perfuse the rest of your arm? So you have two arteries in your radial, right? So if I stick one and I'm trying to clot off that hole that I just poked, I still can perfuse my hand with the other one, right? But if we've been doing ABGs consistently and I can't get it out of here and I need to, not me, but respiratory, needs to progress up the arm to the brachial artery, and I've used this and it's clotted off, what's going to happen to my arm? It's not getting perfused because you only have one artery branch up here, right? So then watching for your signs of perfusion. What are your signs of perfusion? Cap refill, color, temperature, pulse, pallor, feeling. Is it tingling? Is it painful? So the Allen test is that we literally will hold pressure and occlude this artery. So like when you're holding lightly to feel the pulse, you're going to hold even harder to stop it. If the hand gets pale, what does that mean? The other one's not perfusing it. So they do this before they do the ABG to prevent that complication from happening. So they do the Allen test. So if they occlude it and it's not changing the color of the hand, they still have a good cap refill, then I can use this artery for my ABG now. That is what an Allen test is. Before they stick the ABG in. So respiratory you'll see them like feeling for it, but really that's what they're doing, is trying to see if they lose color, slow down their cap refill, things like that. That way they know that they can still use this one because it will still be perfused. Right, so if I'm going to occlude and test this one, that's the one I'm going to stick, because then it's the one that potentially could get occluded by my clot. Right. And so that's the one that you'll stick. That makes sense? Mm-hmm. So this is a type of nebulizer for home care, but it also has the green, yellow, red. You remember what those areas mean? A breathing treatment. What kind of breathing treatment? Albuterol. Bronchodilators, right? To open it back up. And then they do a PAF again. What if it didn't change? It's still yellow. They can step up on their plan if they have a PRN. If they don't, then they go to the hospital. At any time, if they hit red, ER. Right. So there'll be different kinds of whatever, but just being mindful of what the zones mean is the main thing. Yeah, they're probably already having some difficulty breathing, tight chest or something. But education about them doing the peak flow meter before they do their inhaler so that they know where they are and they can evaluate that treatment to see if they're actually getting better or not. Because what does it measure? How much lung they're using. So if with their asthma attack, if things are spasming and closing up, not using my full lung, right? So then COPD, similar care, using similar medications. In shape, right? And it's from their hypoxia, their chronic hypoxia. What? The diaphragm expands. Why? Yeah. So the lung is trying to inflate, but all that CO2 is stuck, right? So if my CO2 is stuck, but I'm constantly pushing in air, it's just going to keep expanding. And can you imagine how difficult that is on your activity? Not fun. It's like when you're 9 months pregnant and just sitting on your diaphragm until they turn. It's ridiculous. So what is this? Yeah, it's a chest tube, closed drainage system. So this is what, once we put in the chest tube, it drains into. So what was you said water? Yeah. So some of them come with a syringe, some of them come with a little thing that you have to tear off and open, but then this is all you have to do to prep it. What does the water seal do? Right. So if this is in my chest, when I breathe, the air pressure is going to be pushing it back and forth, right? If there's nothing stopping it, the air from inside of here is just going to go into my lung. So the water seal it seals it. And so then you have, has a dye once it gets inside and it turns blue in this area. So when I'm breathing, will it be moving my water level? It should go up and down. So if you see this continuous fluctuation, it should be normal. When they breathe, inhale and exhale, it's going to adjust slightly due to the pressure I'm exhibiting on my lung. What if there's a lot of bubbles? It's just continuously bubbling. There's a leak somewhere. So then how do I check for leaks? Check the tubing. So make sure this is still clamped, this is still sealed, and then how is it sealed to the body? To prevent air. Yes. So Vaseline gauze. So it's a moist, sterile bandage. So then that's continuous bubbling. So there's bubbling regardless of when I breathe, inhale, and exhale, right? There's a leak. What if there is bubbling, but only on my exhale? So not continuous, intermittent. So then this is pulling air from inside the lung. So then I had a pneumothorax. So it's still an okay finding, but monitoring it. But if it's continuous, that's the problem, right? So the continuous versus intermittent is what I wanted to make sure everyone understood. Continuous bubbling is a leak. Now, if this gets pulled and it's no longer in the right space, how can I tell on my drainage system? It's not fluctuating because it's not in my lung space anymore. So if it's completely still, it's not in my lung space. Does that make sense? So knowing what your levels are doing is an easy, quick indicator of how your patient is tolerating and if this is actually working, right? So if it gets dislodged, how do I seal it back? Emergency bedside. If you have Vaseline gauze at the bedside, great. Usually in the ICU, we go ahead and have that prepped at bedside in case of that happening. But then just sterile gauze, sterile saline, squirt it on, put it on, seal it. Tape it up, call a doctor. No, doctors place this. Specially trained people can remove them. But nursing-wise, we don't do anything about insertion. I would assist the doctor with the procedure, but they're doing it. But emergency care, if it gets dislodged, it needs to be a wet gauze, preferably sterile. That makes sense because it's an open wound. And then secure it, and then you call the doctor. If I call the doctor first, what's going on right here? It's going to suck in air, and my pneumothorax is going to happen or increase if it was already a pneumo. So you have to emergency stabilize before you call a doctor. Make sense? So similar with the procedure about the chest tube, if it's just fluid that I want to remove for a short period of time, not long period, I can hook it up to a suction canister bottle. So then it just, once this turns on, this is a vacuum and sucks out that fluid. A closed drainage system, chest tube. This is a vacutainer. So it is vacuumed in here, and once I open this up, connected to my chest tube, it will suck out that fluid. That's the incentive spirometer. So how do we use an incentive spirometer? Inhale. Yes. So inhale, and then they have their marker, right? Whereas the PEF is exhaling. It'll be based on their initial assessment baseline with respiratory, and they'll change it for them. Yeah. They'll put their goal, and then they'll mark it, and then you come in and you're like, hey, you're supposed to be at 2,500 today, because it may not be realistic for them to be at 3,500 after they've had a chest tube or something. And so slowly reopening that area is the goal. And if they're, realistic goals, if I am constantly not hitting my goal, I'm going to get discouraged. And so the goal may change by day based on respiratory management. So then if I have my alveoli are closed up, what does that mean? What's that term? Alveoli that's closed up. not inhaling. Atelectasis, right? What's this? Spacer. How do we use a spacer? Open the cap first. Then attach it to your inhaler. Shake before or after you attach it, doesn't matter. You hit the button, the medicine goes into the chamber, right? And then they inhale and they do what? Hold the breath, like 10 seconds. What kind of mask is this? It's a CPAP. What kind of oxygen is it? Nasal cannula. Which one delivers more effective ventilation? CPAP. Does the CPAP necessarily have oxygen hooked to it, though? Not necessarily. Might be part of their prescription, but not everyone has oxygen for the CPAP. It's just forcing the air. So that's more of a they can opt for the nose one if they're a mouth breather, then it doesn't help. This is a non-rebreather versus a Benny mask. Which one has more precise delivery of oxygen? The venti mask. It's more precise. I can know how much my patient is getting. The venti masks have different vents that you attach. You turn the knob and it delivers a precise amount of oxygen instead of a range. Okay? Venti masks are very precise. They are more costly though, you can imagine. But each one of these has a different amount of oxygen and air pressure that they allow. So nebulizer. What are nebulizers used for? Albuterol. Yeah. So the medicine is a liquid, and it aerosolizes it for them to breathe it in, right? Those are fun in the future. And then this is a face tint. This is also commonly used in pediatrics, so you can hold it in front of them. Pediatrics, so if they're having difficulty breathing and they're very anxious, they don't do well with the mask directly on their face, you can do the face tint. There's other ones that are bigger as well. And so then, are they really getting a precise amount of their medication? No, but it's better than nothing because they keep taking it off. Okay? So you might opt for this, may not be your go-to. A face tint. What kind of mask is this one? Yeah, but is it a breather or non-rebreather? It's a breather, right? The non-rebreather will have you can place on these to make it a non-rebreather. So non-rebreather means that, or they are rebreathing their air. So it is a non-rebreather now, but it can become a rebreather. Does that make sense? Rebreathing is that they're rebreathing their CO2 back in. So then they can't breathe back in it. Or that they do breathe back. All right, tracheostomy. What is a tracheostomy? Yup. So they have the hole here. What is this one called? Percutaneous tracheostomy versus when I go through the mouth, it's endotracheal. Percutaneous because it stabs through the skin. So then if I have this is going to wrap around to hold it in place. This is going to go around their neck. This is again a PEDS one. But then it wraps around their thing, holds it in place, and then I can wrap it around their neck. So then if I'm giving trach care and I need to change out the collar, this is the collar, or cleaning, how do I take the collar off? So that's the concern, is that if I don't have this securing my trach hole, it might come out, right? So if I loosen this up and they cough, they no longer have an airway. So no, so you only let go of one side so that it's still semi-secured, and you're gonna hold one finger so that's your dirty hand, and then your clean hand is cleaning everything else. And then you can clean underneath. You would reattach, and then you would clean underneath. Or replace it with a new one. But you do one side at a time so that it's still semi-secured to them, and you can just like, hopefully not let it come out too fast. So then if they have a lot of secretions in their trach, how am I getting those out? Suction. So it's inline, right? I grabbed the wrong one. So the inline suction has a little stopper, and so it's only suctioning when I have it occluded. So when I'm going down, am I making it suction? No, why? You're sucking out all the oxygen that's in their lungs. So you're only going to suction when you're ready to suction the secretions. So you're going down opened. Once you get down or meet resistance, you're going to pull back and suction. But are you going to hold it down? You're going to intermittently do it so that they can still get some oxygen while you're going back and forth. So we usually like when you're pulling out. So then it'll suck, 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 suck. And then you rinse out your tube and you go for another pass. Does that make sense? But we also have Junkers for oral, right? Not jamming it in your teeth. And this is another something that is quite useful. We don't use it very often, again, because of cost. And so usually these are only seen in the ICU. This is a Foley catheter that has a temperature sensor in it. So is this temperature more accurate than my oral temperature? Yes, because it's a central temperature, right? So So if you have someone like in the emergency room, they're pretty sick, so they're probably going to ICU, I would grab one of these. Whereas if they're probably just going to the floor or they don't even have a fever, I don't need to directly monitor, then I'll just use a regular Foley, right? So it's just an option. Thought you guys should know it does exist. So like if you're doing like reperfusion therapy, things like that, when your target temperature, we talked about last semester, we'd be measuring with one of these. And then like if someone has sepsis going on, we need accurate temperatures, continuous. This is also an option. Questions about these? Remember your bubbles. The differences in your bubbles. If they're still breathing, then you don't need a rapid response, then it would just call the doctor to be that you, based on your assessment and looking at everything, you have reason to believe that it's no longer in place because it should be moving. It should be fluctuating. Even if nothing is draining, with me breathing, it should be fluctuating, the level. Continuous bubbles is an air leak. Intermittent bubbles is that there's a pneumo. That's a new finding, call the doctor. But if they got it because they had a pneumothorax, then good. We're draining the air out. That's expected. That makes sense. Experts in asthma.
Oh, where were you? That was good.
Why is it intermittent?
It's triggered by a flare-up.
So how do I avoid?
Avoid allergens or environmental triggers. Take your medication like you're supposed to. Not go to nursing school.
Stress can be a trigger. What else?
Environmental allergens. Smoking.
Smoking. Exercise, yeah. Based on tolerance. What about reflux? Insects. Anti-inflammatory medication? It's because you're messing with response, which is what asthma is an hyperactive inflammatory response, right? So how do we treat it?
Butyral. Your PO med. Corticosteroids for inflammation. Treatments.
What are cromolins?
Meds.
What do they do?
I don't remember.
Anybody remember what cromolins do? Cromolins?
That's not the mucus, is it? No.
Mm-hmm. How does it work? Immune system. It modifies, so then it's modifying the body's reaction, inflammatory response to it, which is what maybe the trigger, right? So what symptoms do we have?
Wheezing, shortness of breath. Asthma.
Just asthma in general.
Increased anxiety.
Chest pain, anxiety.
Use of accessory muscles.
Okay.
Reduced.
Called
Hypoxia.
hypoxia. So signs of hypoxia.
Pallor, cyanosis, change of temperature, sensation.
Might be hyperventilating. Like, as in, the respiratory rate may be increased, but are they using all of their lungs?
No.
Technically, hypo.
Oh, yeah.
But rapid breathing. That makes sense?
Rapid show.
Vomiting. It's actually common with like pediatrics. And then and so it's just part of that cycle, not necessarily directly, but it can happen. And so that's what like parents might come in thinking that they have a stomach bug, they just keep coughing and vomiting and they just don't feel good. But then you listen to their lungs and they actually have some wheezing and find out they haven't been on their medications in a while. And so then you give them a breathing treatment and everything's normal. Open it back up the lungs and everything else resolves. So then what kind of acid-base imbalance would asthma? And then we talked about the different types of oxygen. Okay, what is
The life-threatening condition.
versus status symptomatic? Oh yeah. Where the lungs start closing up and you don't have breath sounds anymore. If you incubate, or
Good? Yes. What is COPD?
pulmonary disease. Okay. So what does it include? Emphysema and bronchitis. Chronic from asthma. So what other risk factors was it? Smoking.
Obesity,
Obesity.
environmental, like,
Exposure. Yeah.
and just,
So those things irritate the lung tissue and are chronically inflamed, and therefore don't do your gas exchange properly. So then that CO2 gets retained. So what symptoms are retained?
tripod,
Tripod position is going to help them. Yeah. The symptoms.
chronic wheezing, chronic wheezing,
Mhm.
yeah.
Clubbing, barrel
Barrel
chest.
chest. That little blue, take a little blue.
You have your chronic bronchitis, blue wheezers, and then the emphysema is the pink puffers. So that picture there, you'll get on your, but mainly COPD in general. Mhm. Depends on how much CO2 you're retaining. And so if they're compliant with their medications, they've gotten early treatment, their physical body may not have had to adjust, and they're blowing off. But it is chronic, and so it also so if you was treating them,
No, high oxygen level. You're not gonna give us high oxygen level. Right.
Hmm?
Give them too much oxygen, their body's so used to being in that hypoxic state that it will stop there.
Now, that has been a common topic, but new research has shown that delaying that extra oxygen is more damaging to them than that potential issue. And so, more so, give them that 4 liters, but frequently monitor them and go down and adjust. But if starting low, they're in that hypoxic state for even longer. And so don't let that delay your treatment with that thought, but keep in mind that yes, you don't want to over oxygenate them because of that CO2 retention. So your CO2 and your oxygen demand, right? So if your CO2 is being stuck and not being exhaled, then you don't have as much of an oxygen drive. So if I'm shoving in a bunch of oxygen, my CO2 is not going anywhere, I'm not going to have a drive to breathe that oxygen in. But delaying that oxygen prolongs that hypoxic state. So now new evidence is asking that we do oxygen early and then back down instead of starting low and increasing.
What is the cost of the oxygen? So like 65%.
Mm-hmm. And so then jump to 15. Like, why are we taking an hour to get to 15 liters? Go to 15 liters if I need to on a mask. But then I will come back down as they're being oxygenated. But then I know my treatment is being effective faster, and I can intervene faster before hopefully they no longer have an airway.
Right.
And so faster treatment, because that has delayed treatment in COPD patients over years and years and years. And so the new research within like only the last 2 or 3 years is asking us to go ahead and oxygenate them, but make sure you come back and if they're doing good at 90, then back them down. But we need to know their baseline. What level are they normally at? So if their baseline that they sit at home is 88%, then I'm over oxygenating them if I'm at 96. But my reading looks normal, but it's not their normal. So that's where that comes in.
The O2 saturation with a COPD patient, what are you expecting it to be? Now, what would be, okay, I need to.
I would aim for 90s, but each COPD patient is going to be different. So this is where our normal for our normal patients is not normal for them.
So if a COPD patient is in the 80s, that they need help. Because you said 88 would be their norm.
Right.
And that would be like scary.
And most COPD patients know what their normals are.
Okay.
And so you can ask that question and they should have an answer for you. Because again, this is chronic and they're used to monitoring themselves at home or they have oxygen at home. Some of them may not be on oxygen at home continuously, but only intermittently. But that is another question you need to ask about baseline. so you know at least where they should be. So I'm not starting at 2 when they're used to 4 liters at home. Complications of COPD, what can happen?
Right.
Respiratory acidosis. What about the heart? Cor pulmonale. What does that mean?
The heart is not getting oxygen.
The heart needs oxygen.
Oxygenated blood. So
Well,
start
they
to
have
fail.
Heart failure.
Yeah,
Yeah, heart failure.
It's
Well, they
heart
have
failure specific to
They have
COPD.
due to the low oxygenation, where they have an increased
What?
hematocrit, the
Yes.
number of red blood cells.
So hematology wise, my body's going to try and kick out more red blood cells with the
Right,
thought that
because-
I'm going to carry more oxygen.
Like they live on a
And so my
mountain.
hematocrit will be higher. So often when we look at our CBC and we look at a hematocrit, we're like, oh, they're probably dehydrated. Well, if they have COPD, it may not be dehydration. That may be their baseline.
The body's trying to compensate
Right.
for the lack of oxygen.
Mhm.
So this would be respiratory acidosis.
Yes. So again, we're not using all of our lungs. So we're not getting enough
Will they
oxygen,
be tachycardic? Will they have episodes of tachycardia?
especially during their acute episodes. Yeah. It'll be also elevated. Yeah. Hopefully not. So then that's your education. What other education do you need to get on?
As long as they don't have their oxygen. They're grown.
It's going to make their inflammatory response progressively worse. Yeah. So they're more likely to have more episodes of attacks or exacerbations because of that continuous trigger causing the inflammatory response. So some people are like, well, I'm already at the state, I'm not going to quit smoking. Like with lung cancer and things like that, which is whatever. But with COPD, no, you're going to make it worse.
Yeah.
There's no, I already have it, oh well, it will get worse the more you smoke.
They can breathe in and breathe out. They're
Yeah.
literally suffocating backwards.
Yes. Slowly, chronic
So just
suffocation.
breathing in and then breathe out.
Mhm. And so that's why it's important for, even if they can't stand the mask, they need to figure out a way to use it sometime. Even if they can use it all night. Something is better than nothing.
Yeah.
Blowing off some CO2 for an hour. Even if you're laying there while you're drowsy, about to fall asleep, but you can't fall asleep with it on, wear it for an hour while you're laying there. Reading a book, doing whatever routine to blow off what you can, and better because you have more oxygenated capabilities of blowing off that CO2 before you lay down, which is laying down can also cause an exacerbation because then they can't breathe again. I have no idea. That's probably more due to the nervous reaction of sleep apnea, not what's causing the COPD. Because you have obstructive, which is like tongue and throat, and then you have neurological. Okay. So also PEFs, the little blue, yellow, green, and also the same medications and treatments as asthma, right?
Weight. Try to get lose some weight.
Lose some weight. Mhm. Not necessarily mucus is what's blocking them, it's more the inflammation. Yeah. And so,
Is that a common?
Right. If you have multiple,
It's
mm-hmm. They can do oral or in steroids for that information. Mm-hmm.
that's
Monte blast. Mm-hmm. Okay. Questions? Anything else about OPD? I've already made the exam. What is it? Fluid in the lungs. What
infected fluid.
Okay. What kind of infection causes pneumonia? Not like specifically, but like generally. Yeah. Bacterial pneumonia.
Isn't there like a, is it viral?
Yeah.
Is it viral? Okay.
So why is the fluid there? How did it get there?
Something trapped it. Can't go anywhere. It's immobile.
Yeah. So the inflammatory response to that leakage gets trapped because something was up above or the water is able to expel it. So then what things have we already talked about that could lead to trapping? Like, what are the two other things?
Asthma,
Yes.
COPD.
Asthma and COPD could cause that inflammatory reaction. And then now we've gotten through our acute episode, and now we're back in the hospital with pneumonia.
Can the flu also trigger, like, can't some people have the flu and then progress to pneumonia?
Like,
Yeah,
so the
COVID
pleural fusion,
Okay.
and then if it transfers through the barrier into the lung and it gets infected, then it's pneumonia. So we'll talk about pleural fusion in a minute. So what are your three main kinds of pneumonia? No, those causes, but like where they came from.
Oh.
Community acquired central associated hospital.
So community acquired pneumonia is when
Get it,
Probably outside.
so it's developed outside of the hospital.
Yes.
So then when they come to the emergency room, is it on their chest x-ray?
No.
Not for community.
should
It
already
should
be there.
immediately be on their chest x-ray because it's already developed outside before they got here. Whereas if they've come in with complaints and symptoms and we do a chest x-ray, but it doesn't show up in 2 days, then it's which one? Healthcare associated, because I sought healthcare treatment. And I only found it because I took an x-ray and got treated.
Okay.
Then hospital acquired after that 2 days. So then with the infectious process, how do they get it? Things inside of the hospital. That's why it's hospital acquired,
So
because they got it in the hospital.
What if you already have signs and symptoms of pneumonia, but it hasn't like
That's the
That's the
healthcare.
Okay.
Mhm.
Okay.
So if you already come to the hospital with signs and symptoms, but then it doesn't develop until a day or two, then that's the healthcare one. Versus I've acquired it from the hospital and exposed to me. Now it's not hospital acquired pneumonia because I had a surgical procedure, endotracheal scope or something like that. I had anesthesia, where I'm not opening my lungs as much, lazy, and pneumonia. How do I treat
That cough factor.
chest therapy? Yep.
Bronchodilator. Incentive Spirometer. I hate that thing.
It's painful.
It is, especially. Cough, chest pain.
Mm-hmm. Pediatrics, what's a common symptom? Not necessarily. Again, like the asthma, the vomiting.
The vomiting. Yeah.
So they just don't feel good and they're vomiting. So again,
So since we do peds next semester, and that's when we got cold, flu season, and stuff like that, in our rotation, if we get to rotate, will you be seeing like pneumonia, lots of pneumonia, flu cases, and stuff like that?
that's usually the main thing, and then with what is it? Yeah, they might not have a fever. Confusion.
Okay.
So they're just acting weird, or yeah, due to the hypoxia. And so they may have never had a fever, cough, nothing. But also with their immune system being older age, it's a little bit slower to react, and they might not have as good of a cough reflex. And so not only is that a risk for developing pneumonia, but also hiding my symptoms, right? So then they come in because they acting weird, and I can't handle her, and this is sudden. I don't know what's going on, or her dementia's gotten worse. I need some help. When actually it's not dementia, it's pneumonia. And so, like in home health, and nursing homes, this is their first thing that their policies say that they're supposed to check for. If acute onset of confusion, in the hospital we're thinking PE, but at home health they need to start ordering a chest x-ray because they got to come to the home health place to rule out pneumonia, because that's usually the leading cause. Yeah. Also, another infection where they have no symptoms, confusion is their only symptom a lot of times for older people.
So what's that pain? Okay, I have this pain in my back when I breathe in and out. It's just like it gets stuck here. Is that has anything to do with?
Do you have a back injury?
No.
Because that's when
It only happened
mine
when I
is
was pregnant
shifting and
and
I'm
everything.
starting to have a bulging disc again. It makes me difficult to breathe. And it's actually pinched a nerve before to where I could not inflate my left lung due to pain, and I got atelectasis and pneumonia in the hospital for 5 days. So I have to pay attention to my back pain.
Yeah, okay.
You just keep going through it. You be going
Oh.
through it. You brave. Like
With my
strong.
TIAs, I've got almost everything back. So
Good.
you see, the only thing that I've noticed still is that like this crevice is like normal, but this one still turns. But my cheeks are normal. My cheeks and my chin and everything is back to normal. It's just that little crevice.
You strong. You real strong.
Related to my but I'm in my last class. So I'm almost done. And it's not
So you know how
3 jobs up there. But thank you. one is influenza.
Oh my goodness.
Yes. It can occur at any age. Yep, yep. Uh-huh.
Yes.
Mutates each year. What's specific about the B strain symptoms wise?
Nausea, vomiting, and
Nausea and vomiting is more prevalent with B. So if I have a flu shot, can I still get the flu? Okay.
unfortunately.
How do I treat the flu?
Just doesn't actually treat it. It just makes the duration of the virus.
Right. So I won't have my symptoms for how long, but I still have the severity of my symptoms. So after a few days, and I feel like crap. So then, symptomatic wise, what can I do to help with my fluid,
Just medication reduces fever.
If
What's
it's
that window
48 hours
within 48 hours?
within
What about with
contact within 48 hours.
contact within 48 hours? How do I prevent
You can get the vaccine.
Stay away from people that have it.
social distance?
In this pandemic.
Don't touch your face. If you cough, elbow,
Upper sleeve.
your tissues.
Don't leave them laying around.
Very similar.
So if somebody like blows their nose in a tissue, they have the flu. They put the tissue down. They
And it's on their
pick it
bedside
up.
table, and
But then somebody touches the table,
Mhm.
they'll still get it. And does it have like that window where like it's still active or like the bacteria or
Yep.
whatever?
and so it can still be a live virus that can still infect someone. I think the flu is still like 24 hours, and then like COVID has been shown to be like 48 or 72 hours. So then what kind of precautions for the seasonal flu? What about like contact precautions? Droplet.
Airborne and contact.
Droplet is for seasonal. If it's the pandemic,
Oh,
it's the airborne. So then with airborne, what kind of mask am I wearing?
respiratory.
N95 respirator. Yeah. So then with the step, anything below it is also applicable. So contact and droplet. And then with pandemic is going to be all three of it. So contact, droplet, and airborne. So,
So with, sorry, I have a lot of questions.
very good.
So with COVID, like you know how people can be asymptomatic, can you be that with flu?
With influenza, yeah. So they may not have a very severe reaction. It may just be cold or runny nose or really
but it-
nothing. And so they're not really reacting to it, but they're still being able to spread it. And so if you've been exposed to it, that's where I would appreciate if you were to come find out tomorrow that you had the flu, that you would tell us so that we can now be on alert for any symptoms in case I then take it to my grandma and she dies next week. I don't blame you.
Right.
So then fever, aches, pains,
Chills.
chills. Yes, the RIDT test. Thank you. The rapid influenza diagnostic test or whatever. Highly unreliable. So if they get a negative, mhm,
I just don't get
it's
that.
like a Q-tip one, and so it's the outer nose. Whereas you get like the fuzzy one is all the way rhino. So then if they still have all the symptoms, they meet the criteria, and especially been exposed, but their RIDT comes back negative, you would still treat them as if they have it. even diagnose them as it.
So it's like because it's like a
I mean, it can be confirmatory if you have multiple possibilities, like with COVID versus flu versus RSV season, especially with like kids. And so knowing which one it is to know what severity and complications to look for can be helpful. But plan of care is kind of the same. It's just the complications are different. Okay. I think that's it. It's also airborne. Pandemic is also airborne. These are just some other things that to kind of keep in mind, and those people that are more visual learners, like the 6 Ps of dyspnea. A lot of these week anyway, but all of the 6. So you have your bronchial constriction, which could be pneumonia, and pneumothorax is where that air pushes the lungs and that part of the lung is not open. And then the same thing with thorax, plural. So it's pushing it, but it's not inside of the lung of that layer. So then you have your common cold treatment, can be very similar to that treatment. But if it's also throat, that's when it's pharyngitis. Bacterial pharyngitis, throat irritation, technically, all of my diagnoses, I'm a physician. Oh, you have rhinitis, and you have pharyngitis, and you may have tonsillitis, because it's just inflammation, right? So it's an umbrella term, so some people only think of pharyngitis as bacterial. With all of these, we're not using all of our lung, right? So either something's blocking it, fluid, air, fluid on the outside, or constriction. So then with all of these, what kind of acid-base imbalance am I having? Acidosis. And then acute respiratory distress syndrome. What is different? Yes, it's acute. So if I'm treating one of my constrictions and it doesn't respond and it keeps progressing, technically I'm in acute respiratory distress syndrome. It is not necessarily when everything is locked off. That is the bad part, and then we're definitely in ARDS. But we're beginning when we're not responding. But what is going to stop? Then more oxygen, more force, more open. So bronchodilators, anti-inflammatories, or if it's becoming rapid, right? But this is essentially when ARDS is when you intervene and it does not respond. So then, technically, in PaO2, they say less than 60%. So that treating it, I am still only oxygenating 60% of my lung. And that is a concern, right? We want at least 80% of our lung working at any time. That would be nice. Below 60. Okay. Now we're going to do some case study questions. And so now this is when you're going to use your little dry erase board. So read this with your group, discuss, and just write on your board which one of, which one of those you would respond with. Ready? What do you think? Yeah. So why not bradycardia? Yep. Compensating for the lungs, so I'm going to increase my heart rate, trying to get that oxygen in, and also a stress response that I can't breathe, so I'm stressed out, so my heart rate increases. Or you just had a breathing treatment, so your bronchodilator is going to speed up your heart rate as a side effect. There's multiple reasons to have tachycardia in this instance, or normo, but should I ever have bradycardia? Not necessarily, unless that's my normal. But I would think it would increase to a real normal if I got a bronchodilate. But yeah. Okay. So next. What's the step down? What would you do first? What do you think? It's not a select all, so it's a one option first. That's not an option. Yeah. So what are we doing first? Of these options, these are the only options you have. What are you doing first? Ready? Yeah, that's not an option. Yeah. So she has not improved. Not improved. Her O2 is still 82. I need to keep her from. Yeah, but she's not getting oxygen. Her treatment didn't open her lungs up enough. She's trying to breathe, but she's not ventilating. She's trying to breathe, but she's not ventilating. Her lungs are not getting enough oxygen. Low what? Oh no, I'm working to breathe. I'm gonna work as fast or as much as I need to. Yeah, labor as in working. So I need help. She's not being fixed with what I immediately have, so I need help. So I'm gonna call rapid or call the doctor or any other response there, as well as I would increase her oxygen in the meantime while people are waiting. But I'm not gonna let her sit at 82 for another 30 minutes. Rapid response team is there. Doctor gets there and writes some orders. Which one would you implement immediately? So first. Is that what she said? So gonna increase her oxygen. Also, I'd be like, Doc, that ain't gonna be enough by 1 liter, but okay. And then perform the new ABG. Why am I doing it 30 minutes after I've intervened? Using it as an evaluation, right? What is the methylprednisolone going to do?
Or increase.
I'm gonna treat because so why do I need to confirm things? But I'm gonna use it after I intervene to evaluate my intervention. So then you're looking at 30 minutes after you intervene to see. I mean, your SpO2 may climb back up within the next few minutes, but blood oxygenation wise, it's going to take at least 30 minutes to see if any acidosis has been corrected. Okay? So then I would go B, C, D as I'm waiting on a room for the ICU. But if ICU comes first, then they get them before they get the medicine. So they're going to get to ICU as soon as possible. Then I'm going to do what I can while I'm waiting on the room to get there. Especially with respiratory, when you got to intervene. So, in ICU for 3 days, back to 99 on 2 liters. Let me see. Yes, it is a select all offline. I did not put it on the slide. Okay. Regardless if she's had education before, if they're going home with oxygen, they're getting education again. If they had home health before and they got admitted to the hospital, they cannot have services for hospital and home health on their insurance at the same time. So technically, by being admitted to the hospital, they are discharged from any home health or hospice services. They have to then be readmitted to home health after discharge from the hospital. So then you need to make sure home health is still in place before they get discharged. There would be like a care coordinator or a discharge educator that would make sure that these things are in place and that they have. So even like with hospice, we cannot discharge them from the hospital until we have confirmed that they have all of their services at home. There's oxygen tanks at the house. There are signage at the house. There's plenty of supplies for her at the house. It has already been delivered before she leaves so that she doesn't go home with no oxygen and wait 2 hours for them to get there, and then she's back in the hospital in respiratory distress again. So home health has to be in place before they can leave. Okay? What about cigarette smoking cessation? Medication regimen compliance. Yes. But if it was just a trigger, she might have another medication. She may be on a preventive antibiotic just to make sure she doesn't get pneumonia again, or maybe she's continuing antibiotics in the hospital. We always do a med review before discharge. That includes their home medications and any new medications. And then worsening symptoms to call 911? Yes. Always. Why not decreasing fluid intake? So we want them to increase their fluid intake as much as possible, usually like 2 or 3 liters a day, but not too much, especially if they have kidney failure, because then fluid's going on the lungs. If they already have heart failure, it's also another concern. But general population, don't decrease your fluids. If anything, increase. It's going to help you move those secretions. And so on that point, mucolytics, how do mucolytics work? They pull fluid to the secretions to thin them out. So then intravascularly, I can get dehydrated by taking a mucolytic. Yes. Because they overlap, and then you're going to be dehydrated, hypertensive crisis. Yeah. All right. One answer. So how do I know it's worsening? Which one of the statements? A is because I have a problem. Versus D is I know when I have this problem, I know how to fix it. So it's not necessarily a problem right now, but A is a problem right now. It's the wording of it. I have noticed that doesn't mean that they know that when they are having issues, that's more evaluation education. They already know that. That's not necessarily saying that they're having that problem now. Versus A is that they have this problem. So they uh-huh. They're thousands of dollars though. Productive cough in the morning, normal. Yeah. What about the weight gain? Why would they lose weight? They're increased work of breathing, they're increasing their metabolic demands, and so then they're using up more of the carbs. So actually they need to eat more because they're prone to lose weight, not gain weight. So if they've gained weight, then that's not really necessarily a symptom that it has worsened. If I've lost weight, then my metabolic demands have worsened, which means I could be breathing harder. Okay? Eventually, but not a symptom right now. It's not a symptom. That's more of a risk. All right. Next. When would I intervene on a chest tube? Okay. Should there be water in the chest tube chamber? Yeah. Should there be rising and falling with inhalation and exhalation? Should there be bubbling intermittently? Either on exhale or when I cough, it forces that air out, right? So all of those are expected. But if the bandage is loose, so it should be airtight, right? Emergency situation, you need to plug it up, suck it up. You need just sterile saline gauze. Okay.
You said it's a no.
There's air in that space if it's intermittent. That may be why we have a chest tube, to drain that air, to pull it out. And so it could be an expected finding. But if it's continuous, then we have a leak and potentially worsening of our pneumothorax because the air is going back. So PF in the red zone. Take the bottle. By the doctor. What do you do about it? What if it's a pager and he doesn't respond for 30 minutes? A and then C. But what's first? Prior reaction. Yeah. They're like, so this is what's happened, and it's still not working now. So I'm gonna give the rescue drug. Would be faster than calling prior doctor because I need to leave now. So that wasn't an option. So so red zone is less than 50% of their lungs is being used. So definitely concern. Yes. It's likely if it's patient individualized, like their insulin inhalers, eye drops, ear drops, all those individualized things are going to stay in the room just to prevent contamination. And like if two patients are on similar eye drops or whatever, then you're not using one for one patient, getting them mixed up in the Pyxis. So once it comes out of the Pyxis and goes into the room, it doesn't leave the room. So if like they have the insulin pens, they're going to be patient specific also. So they'll be all in that patient specific box. Another case study. So Which one requires immediate circulation? Now, I would intervene on this first. Okay. If they have blood pressure medicine, I might make sure that they get it today. Heart rate is concerned, but it's probably in response to the oxygen.
Right.
And so their way is gonna fix that, probably. And then temperature, I'll give them some Tylenol, but first I'm gonna do some more. So, oxygen is not on the concern. Dealing with the same thing would be the respiratory rate. Yep. So I can tell them about how to more effectively breathe, maybe position them time, take deep breaths, oxygen. But if they're compensating and they're breathing this fast, I don't want them to be doing this for very long, right? Because you're going to give up. Yeah. So you get these orders. Which order should you do first? Why? Because they're hypoxic, right? If this was a management of care, which one would be appropriate for the UAP? Start fluids, put on oxygen, not supposed. Can they do blood? They can collect them and and then can they turn them off? No. So for donation, in certain areas, yeah. Or they can call. You don't have to be the one to call. So then, if the stem changed just with those options, yes, I would want to do oxygen, but the UAP cannot do that, right? They can replace it, but they can't initiate it. Because then it's already part of it. Yeah, they can collect the urinalysis and send it off. Well, then they can but an unlicensed assistant person. So like a PCT, not even like a CNA license. So 2 hours later, patient has a weak cough, crackles, lower lobes, 90% O2. We're going to do first. Airway. So how are we going to intervene on airway? Coffee breathe, spirometry, sit up in the bed, maybe get up, take a deep breath. If none of that works, maybe they need a dilator or maybe a retaining fluid. So that's
I know she's confident clinically, but how is it an airway form when she's at 90%?
and fix anything that could be blocking our lungs to opening up completely. And then if that doesn't work, then I'm gonna with breathing and then circulation. Unless it changes. Foundations. Nurse understands that which of the following is the most common symptom of pneumonia in older adults. If it didn't say older adults, fever, cough. You're confused? Are you old? So older adults, the hypoxia is going to get them first before any other symptoms. So they get confused. Because also the infection. So same reason, but then it's like septicemia. And so acidosis in a different way. So then it's metabolic acidosis instead of respiratory acidosis. All right. Importance of the pneumonia vaccine. So that's a little 5. We're going to see where y'all are. Requires an intervention by the nurse. Versus same question, but STEM says that they full question. Because if you jump to airway, awesome, that might be great, but I'm asking about a UAP. You know, so you might know the answer, but make sure you read the whole question because it might change your answer. You're looking for the wrongs. Yeah. And then the Pneumovax. So, A, C, and D. So once you get the Prevnar, still need a year later. Okay? You're going to need both vaccines, not one. A is wrong, or your suggested. And then if you're over 64, only the flu vaccine. What's the age cutoff for adults? Is 65. And then once you're over 65, or there's no protocol, Prevnar and Pneumovax. If you're less than 65, then it's just the pneumonia vaccine. Have history of complications and risk factors. But once you get 65, everyone is in this category. Anybody 65 in the room? This is the last thing. I just wanted to quickly go through some reminders or tips. So alkalosis has a K, so it's kicking the pH up. Acidosis has a D, so it's dropping the pH. I don't know why this. I guess it has to be a quick. So then on my pH scale, with my metabolic, with my upper GI vomiting up, where's my pH going?
Yeah, it's going up.
Going up. So it's same direction. So if it's up, it's alkalosis, right? What about my reflexes? Same direction or opposite? What do you think? Hyper or hypo? Hyper. Same. And then my potassium, is it the same direction or opposite? Potassium is opposite. So watch this trend. Lower GI diarrhea, so it's going down. pH is going to go down. Reflexes are going down. So they're going the same direction, but potassium is going opposite. Respiratory, hypoventilation, so low. pH goes down, low. So then I get weak. My response is low, and my potassium is still opposite. Hyperventilation, using extra, also going up, and seizures. And then potassium is also opposite. So reflexes are going the same direction, the pH is going the same direction, but your potassium is always going opposite. You see that? Quick reference. Yeah, you're going to get this. I wasn't clicking for them. So it's a quick summary, easy